This session is part of the larger Comprehensive Prevention Plan Learning Series. The series maps directly to the 9 readiness domains for California's Family First Prevention Services, that's FFPS, program and addresses requirements outlined in the ACL 2223 and AB 153. If you missed any of the sessions so far, because there's been quite a bit, you can find replays and resources on the Caltrin website. There's a link in the chat. Thank you so much, Stephanie, for dropping that. To get us started today, in today's topic, I'd like to introduce our first speaker. That would be Dana Blackwell. Dana Blackwell serves as Senior Director of California Strategic Consultation at Casey Family Programs, that's CFP. In this role, Dana is responsible for leading CFP's work in the state of California to include statewide programs, initiatives, and system improvement activities. So good morning, Dana, and you can take it from here.
Great. Thank you so much, Jess. Welcome everybody to today's topic, preparing the workforce for providing prevention services. Before we get started, I really want to identify 2 tools that have recently come up. I think we can advance the slide. 2 tools that have recently been shared with you all and are currently on the Caltrin website. The first is the CPP Implementation Guide, Plan Development Phase. We released this guide in September, mid-September, and this guide is not different in terms of content. What is different is that it's a little bit more user and reader friendly. It tells you how to use the guide, and our hope is that despite that it's not a required tool for you all to use, our hope is that it helps you as you are developing your CPP. There is a feature in the guide that talks you through how to use the guide, and it is bookmarked for each section of the guide. There also are tools like fiscal tools, asset mapping tools, logic model tools within the guide to help you through your development phase of your CPP. We're excited about it, and we hope you are as well, and that you use it going forward through submission of your plan in January 2023. The next tool is the Child, Family, and Communication Wellbeing Communications Toolkit. This toolkit is embedded in the guide, but is a separate tool. I think of it as a plug and play for communications. It's really important that as you're developing your comprehensive prevention plan, that you're engaging key stakeholders in the process, that you're letting them know what's happening, that you're inviting them to the table as part of the development. And there are several tools in here that you can use to engage your communities. There are PowerPoint slides that you can use and make your own. All of the tools in here are tools that are editable and ready for you guys to really make your own and include your context for your county. So it is a plug and play. Again, this is not a required tool. It is a tool that we hope can be supportive of you as you implement your comprehensive prevention plan. Again, these can be found on the Caltrin website. Next slide, please, Kush. So now, today, we are going to continue with our learning series with this form on preparing the workforce to deliver Family First Prevention Services. The form will focus on strategies for establishing a prevention mindset and resourcing training materials and tools for those in the system that will be providing direct EBP services or case management. Today, we will be joined by Dan Edwards, who's a licensed clinical psychologist and EBP consultant, Jennifer Rolls-Royce, Director, California Evidence-Based Clearinghouse, and Kelly Winston, the Chief of the Family-Centered Safety and Support Bureau, California Department of Social Services. And the forum will be moderated by Kush Cooper, President and CEO of Implicit. So Kush, I will hand it over to you. Have a great forum, everybody.
Thank you, Dana. So here's how we're going to spend our time today. Right after I show you this agenda, I'll do an introduction to the domain we're calling workforce development. And then I will turn it over to Kelly Winston to do an overview of the entire the framework for the state's workforce development plan. And that framework actually has 3 tiers in it. And then after Kelly shows you the framework, we'll move to Jennifer Rolls-Royce to talk about tier 1. We'll get a lot further into that here in a moment, so don't worry about it for now. Then we'll take a quick break and come back to Kelly to talk about the 2nd tier. And then we will move to Dan Edwards to talk about the 3rd tier of training, which is EBP specific. After that, we'll take another break, come back for some closing reflections, and then open it up for a question and answer session. We do have some questions we've collected over the registration, and we will be teeing those up during the Q&A, and then we'll also be taking questions from the audience. We aim to wrap up around 12:50 and end no later than 1 p.m. There's a host of resources that'll start to be dropped into the chat as we go. And without further ado, let's get into it. So this is the workforce, that should say workforce development, the workforce development domain. And why I keyed in on that difference is that workforce development is so much more than training, right? It is how you select the folks that are going to do the work, how you train them, how you coach them, how you assess their performance, what policies they follow, all that goes into workforce development. We think of it as just training, but it's more than that. So let me locate our conversation in the readiness domains that we've been sharing with you all along. We actually started with fiscal and funding, so folks could start to think through who they need to have at the table and what funding streams were going to be brought to bear, so they could gather their governance groups and collaborate with their stakeholders, right? So we did fiscal, then we went to governance and stakeholder collaboration. So then those groups could start to have a conversation locally about program design and service array, which is the next readiness domain. And that should be where many of you are right now, is finalizing who your target populations are, negotiating that with your stakeholders and your governance groups, and then figuring out what service array do you have versus the service array that you want to serve that target population. And we covered all that on August 17th. Once that conversation is in motion and starting to be documented, one can turn their attention to, for those selected services, right? How am I going to assure quality and outcomes, both for EBPs and not for non-EBPs, both for process measures and outcome measures? How do we do that with this service array? We talked about that on September 21st, which leads us to sort of the other aspect of the conversation when you choose your service array. One, how are you going to manage quality and outcomes? And then how are you going to select, maintain, and support a workforce that is going to be well retained, well-educated to provide the prevention services that you've laid out in your county. So that's where we're gonna keep the conversation today. And this is the last of the readiness domains that we're going to talk about this year. We will have a forum on November 16th that's going to put all together what we've talked about thus far. So readiness domains 1 through 6. And we will start to move to talking about things like policies and reporting and automation next year when we get into the nitty-gritty of implementation, like business processes, data systems, and things like that. I just wanted to show you where this conversation is nested. So what goes into this domain, right? Workforce training and development. So you can imagine, you know, prevention gave us 3 tiers: primary, secondary, and tertiary. And so it's why not have 3 tiers for training? They follow, they're kind of analogous to the tiers of prevention. So the first tier, right, you could say it's a universal tier of training, or everyone who's going to be supporting children and families in this prevention system, CBOs, service providers, child welfare workers, probation workers, others. What are the prevention frameworks, mindsets, and principles that serve well to contextualize the work ahead? And that includes linking prevention to the integrated core practice model here in California, which shows us how we can collaborate at the leadership and individual levels so that we don't have fragmented service delivery to our children and families. Right? So you could say that's the broadest tier that everyone can benefit from, no matter what kind of work you're doing in the system. The next element, or the second tier of workforce development that's required, is going to be for those doing casework. Right? Mostly those will be county staff, right? Particularly doing candidacy determination, but it could also be service provider staff that are contracted out. AB 153 and FFPSA allow for that. So training on how you do assessments that end up with candidacy recommendations. How do you do candidacy recommendations based on determinations based on those recommendations? How do you do safety monitoring and risk assessment in the context of prevention? Right? We know how to do it in the context of open cases, but how do you do it in the context of prevention? And again, at the case work level, how do you bring in the core practice model so families are partners in their journey to healing and well-being? Right? So that's the second set of conversations. Third element, or third tier, are specific EBP training for the practitioners who are going to be delivering those EBPs that have been locally selected. So if you've selected motivational interviewing and brief strategic family therapy, it's how are you going to train your practitioners who may or may not be employed by service providers, right? Largely they will, but how are you going to get those folks trained? Or there's the service providers equipped to train their practitioners. How's that going to work? And then for all of these, what's your training plan? How are you going to sequence things? What's the schedule? What the curricula going to look like? Who are the trainers going to be? And what are the training contracts going to look like? And how are you going to fund all that? That's all part of this domain. So now I'm going to turn it over to Kelly Winston, and she's going to talk to you about the framework that holds all of this together and the way the state is thinking about it. Kelly, please go ahead.
Thank you, Kush. Welcome, everybody. So my name is Kelly Winston. I'm chief of the Family Centered Safety Support Bureau here at CDSS, and working with my colleagues there and all of our training partners in developing a proposal for how we'll do training at the state and across the state at the county level. So if you can go to the next slide, please. Okay, so I just want to share with you all, all of this basic information regarding our plans for workforce training and development. This includes what was in the most recent draft of the 5-year state plan. And if you're interested in looking more at that prevention plan in detail, I think we're dropping a link in the chat there. And just know that this is a version that was shared with stakeholders back in April. But since then, we have been working hard to update that based on all of that great stakeholder feedback that we received, and refining this training proposal so that we can submit our prevention plan to the Administration of Children and Families. And we're hoping to do that in the upcoming weeks. Because federal law aims to ensure that prevention services are delivered by a well-trained professional workforce. Those are the words that they use in the federal law. In order to achieve that, as Kush mentioned, we have these 3 tiers of training, and they're intended to target the diverse audiences needed for the Family First Prevention Services program. This is to ensure that each audience has the information they need to play their specific role in the comprehensive prevention plans at the local level. Next slide, please. Okay, so the first tier we have here is focused on prevention principles. So these principles are intended to set the tone for shifting that mindset, less so on serving families in the child welfare system and more towards engaging families earlier or more upstream to support their well-being prior to contact with entry into the child welfare system. Tier 1 includes sharing the vision of the Family First Prevention Services program outlined in the state's prevention plan. This is to build service capacity where disproportional representation in foster care is the highest, and increase equitable access to culturally relevant services. This tier also aims to help increase understanding of how systemic racism and implicit bias contribute to such disproportionality. Some of Tier 1 includes several trainings already available through the Caltrin training website, as well as this learning series to help counties develop their local comprehensive prevention plans, or CPPs. Tier 2 focuses on foundational knowledge, as Kush mentioned again. These skills are for those direct service staff and their supervisory and fiscal colleagues. This tier includes both case management aspects of service delivery, as well as the overall understanding of the Family First Prevention Services program, federal requirements, and this is intended to be delivered to any staff offering services in both the Title IV-E pathway, so in a child welfare agency or probation agency, as well as those staff who will be a part of the community pathway. We think that this is going to be rolled out in 2 different phases. The first phase focuses on knowledge building and skill building, and this is intended to occur prior to the delivery of any services that a county might be doing to roll out those evidence-based practices. The second phase will be likely closer to once we have available our first version of CWS CARES. Most of you are aware that federal requirements tied to documentation of prevention plans, service delivery, and the fiscal information that's required to be collected for reporting will happen within that CWS CARES system. And training on those items will be available closer to the rollout of that system. And then finally, Tier 3 is designed to help local agencies working on their CPPs better understand each EBP so that they can choose which of the services they'd like to include in their plan. This is also a helpful tier for organizations who are looking to develop the capacity to provide an EBP so that they can be part of a local comprehensive prevention plan. And while there's a host of individuals we aim to reach with these 3 tiers, the heavy lift, I think, we believe is much of the skills-based training and the support that will be aimed towards those providing direct services. This is that Tier 2 foundational level. There are these 2 main audiences included in this tier, and we want to really focus that knowledge building and skill building on those direct services staff. We call out the differences between the Title IV-E pathway. We'll likely be training child welfare and probation agency staff, as well as their supervisors and managers. And this can include the staff for tribes who have a Title IV-E agreement with the state and are planning to develop and set up their own FFPS prevention services as well. In the community pathway, the audience is, again, those community-based organizations who are contracted with a county to deliver EBPs. This could be family resource center staff providing case management and even the delivery of some EBPs. This could be a school if they have a service available that is an EBP, or a CAPC, maybe a local behavioral health program. And even tribal social service agencies that have some services available or want to do the coordination of case management. This is going to look different in each community depending on the local prevention plan and how that's built. And I think it's back to you, Kush.
Yeah, thank you very much, Kelly. So that was the overarching framework or container, right, inside of which these 3 tiers of training sit. And now we're going to zoom in to the tiers, and we'll start with tier 1. Jennifer.
Great, thank you. So I'm Jennifer Rolls-Roots. I'm the program director for the California Training Institute, which has already been offering a lot of training that would fit in this tier 1. So we'll talk more about that. But we're going to start today by talking about the different levels of prevention. Let's review that and where your work currently fits in. We'll review 2 common frameworks that can help guide your county's prevention plan and just your work in general. We'll talk about some prevention strategies and actions that you can take on an individual, organizational, and community level. And then finally, we'll end by reviewing the training that will be available on these topics statewide. Next slide, please. Okay, so you may have seen this image before. I'm going to share a short story from the book Prevention is Primary by Cohen, Chavez, and Shahimi. Excuse me. You may have heard it before, but I think it's really helpful to explain prevention in kind of plain language, and also why we use the term upstream. So the story goes a little something like this. While walking on the banks of a river, a passerby notices that someone in the water is drowning, and they help pull the person to shore. After pulling them to shore, the rescuer notices another person in the water who needs help. Before long, this person notices that the river is filled with people drowning, and more people are needed to come to the riverbank to assist that initial rescuer. Unfortunately, some people just can't be saved, and other victims fall back into the river again after they've been pulled out initially. Finally, one of the rescuers starts walking upstream. Another rescuer says, "Where are you going?" She replies, "I'm going upstream to see why so many people keep falling in the river in the first place." And as it turns out, there's a bridge across the water upstream. And that bridge has started to collapse, leaving holes in the surface. And people, sometimes groups or whole families, were falling into the river as they tried to cross the bridge. The upstream rescuer recognized that the repairs to the bridge itself were necessary to prevent other people from falling into the river in the first place. Thus, by ensuring the conditions that people weren't having to be rescued over and over, preventing them from ending up in the water to begin with. When we talk about moving upstream, we're talking about focusing on strengthened families, repairing the bridge, so to speak, the community, working across sectors. And so for this reason, when we talk about reimagining prevention, we're really talking about moving upstream towards primary prevention, preventing people from needing a lot of our services in the first place. So although this little story is just a conceptual framework and a helpful analogy about the different levels of prevention, I think that we can also use it to kind of place where we are on this system, and also help to think about strategies and actions that we can take going forward. Let's also review the levels of prevention, and as we do so, think about how they relate to the story of the river and the bridge. So I think we're dropping a link to the prevention framework document for this is from OCAP. So you're seeing on here a portion of their framework for prevention. This document outlines 3 levels of prevention, starting with primary prevention. And these are activities that are directed at the general population to strengthen communities and improve child well-being. And they focus on the social determinants of health, which we'll also touch on in a few minutes. So these activities could be community-wide, they could be school-wide. Basically, there's no need to screen in to get these services, or you don't have to be considered at risk. So truly universal. Secondary prevention are activities that are offered to populations that have risk factors that may be associated with issues with well-being or child maltreatment. These could be things like poverty, parental substance abuse, insecure housing, etc. Lots of different risk factors that I'm sure you're familiar with. These programs seek to build protective factors and mitigate risk factors. These are targeted programs. They might be for families that are identified as being at risk, or it could target an entire community. For example, if poverty is higher than average in that community. So you might target at different levels, but these are targeted approaches. And then lastly, we have what we would call tertiary prevention. This is where the abuse or neglect has already occurred. And now we're really intervening to address trauma, to improve outcomes for the children and families, and to prevent reoccurrence or reentry. So when we plug this framework of levels of prevention back into the river, it looks something like this. And if you can go to the next slide, thank you. So what you'll really see here is that the bridge at the top is where primary prevention will occur. So that's fixing the bridge, strengthening the community, the where our families live and work to prevent anything from occurring in the first place. And then as people are starting to wobble and fall into the water, it's getting them out quickly. It's addressing the needs. And then really tertiary prevention is kind of, it's already happened and they're in the river, maybe they're drowning, they need services. And so it's that downstream approach. So I'm curious to know from the folks who are here, where do you see yourself? What level of prevention are you currently working in? And so if you can go ahead and drop that in the chat, if you're comfortable sharing your organization, your agency, your role kind of thing, do that. But basically give us an idea. Do you really see yourself currently more as primary, secondary, or tertiary prevention? So go ahead and drop that in chat. We'll give folks a second. Tertiary, primary, secondary. Yep. And I think when we looked at that poll earlier, we've got folks that are all over the place. So we've got some that have really been in tertiary and others that have been more already in primary and secondary. So some of this moving upstream is really for the the secondary and tertiary folks. So I know that traditionally some agencies have felt more siloed in their level of prevention. So probation or child welfare, we might think of something like probation as being kind of way downstream. You know, you've got these families that are really coming in at that tertiary, those people are in the river. But we can start moving services upstream. And let me give you an example. So we did a presentation earlier this year, and one of the speakers was a supervising deputy probation officer from a Mountain Valley County. And he talked about the work that his county has been doing already to shift probation to a more upstream mindset. And I just wanted to tell you some of the, not the exact wording, but pretty close to what he said about it. So he said, probation isn't a term typically associated with prevention in the community. However, with implementation of the children's system of care, it's important to understand that probation's job has changed from a punitive approach to restorative justice, requiring multiple community partners to swim upstream to minimize entry of juveniles into the justice system. So he's clearly speaking about the need, this concept of moving upstream to and addressing why kids are coming in to probation in the first place. He also said, our goal is not to treat families in silos. For example, saying that's a probation family or that's a child welfare family. Instead, we need to shift our approach to this is our family, our county's family. All county agencies, whether you're preventive, tertiary, wherever you are, need to start thinking with that mindset. We need to ask ourselves, how can we as a collective create systems for not only helping families that are in the system and minimize reentry, obviously, but also prevent others from getting into the system in the first place. So really what he's saying is we need to focus upstream. We need to prevent these families from getting into the river in the first place. And that's really what we're doing here by trying to move our attention more to primary prevention. All right, next slide, please. Thank you. So here are some examples of different activities and strategies that fit in each of the 3 levels of prevention. And again, this is from this OCAP document where a link was dropped earlier. And so, sorry, I'm just clicking off that. Think about the level or levels that you typically work at. And you might want to use the chat to share some strategies that you're currently using. Which of these strategies are resonating with you? And if you are in something like probation or child welfare, where you typically would see yourself as tertiary, are you already doing some of these things that fall in the primary and secondary area? What can you be doing? And so sometimes we have a concept of what we're doing, and you might want to think about how you would pull some of these other earlier primary and secondary prevention strategies in. And then, of course, people are working at all different levels already. We saw folks earlier who were saying, actually, I see one right now, secondary and tertiary, mostly with some primary. It's likely that even if you're in largely tertiary, you are doing some things that fall into these other areas. So take a quick second and take a look at these and think about what are you doing, either as an individual or an agency, across these different levels of prevention. Okay. All right, next slide, please. So if we want to reimagine prevention and move our work more towards primary prevention, we first need to look at what are you already doing, but we have to think about what is involved in shifting our mindset and shifting ourselves away from, for example, strictly doing tertiary to moving more upstream. We need to think about how you're already doing prevention and how you can make small tweaks to what you're doing to shift upstream. And then also to think about how, regardless of what level of prevention you're doing, how you can take action to strengthen families in your work and every family that you come in contact with, regardless of where they are in the system. Okay. Thank you. Stay on that one. All right. So what is a prevention mindset? We had a whole webinar on this earlier in the year. I'm just kind of giving a quick overview. So a prevention mindset isn't really a definition. It's more of an action. It has some assumptions. And so that's what we have here. And these are assumptions that are part of a prevention mindset, but not limited to. And so this might be action that you would take at your own county. What does it mean to move upstream, to move more towards primary prevention? But let's take a look at some of these that came up. It's accepting that collective challenge. That your whole community wants to reduce child maltreatment and improve child family well-being. It's having a shared vision, and that's part of what the comprehensive prevention plan will do is get you that shared vision at your county level. It's really focusing on changing community conditions, recognizing that no one provider can change all of this. We have to work as a community. We have to fix that bridge so that people aren't falling through rather than just supporting them when they hit the water. It's thinking about equity, making sure that we're meeting people where they are and addressing their individual needs. This one is key, making sure that community voice and partnership is a huge driver of the change. People with lived expertise and lived experience need to have a role at the table in how we move upstream. Again, everyone has a role. You have to collaborate. We have to look beyond silos. And I think for too long, we've been very siloed in our agency. This is child welfare, this is probation, this is mental health, et cetera. We've got to kind of really work together. And there are so many mechanisms at the state that are helping to encourage that. And then lastly, understanding the need for measures and data. And as we're doing this work, making sure that we're paying attention to disparities and any inequities that are present. And again, this is all a big piece of that comprehensive prevention plan. Okay, next slide. All right, so why do we need a prevention mindset? Really, to move upstream, it is going to require that we all do some overhaul in what we're doing. We need to change what we're doing. Like I said, we need to break down those silos. We need to work more across systems. We need to make sure we're focusing on equity, being culturally responsive, meeting the needs of the families in our community, and collaborating across systems. Both are public serving systems like child welfare, probation, et cetera, but also working with our community partners, our family resource centers, our community-based organizations to really move us all in one direction. Okay, next slide. So how is a prevention mindset beneficial? In other words, why should we be thinking about repairing that bridge from our upstream example? So this might be repetitive, but just to bring this home, we know from data that focusing on primary prevention, that is intervening early and providing supports, decreases the likelihood of higher level services being needed down the road. So if we can get there early, we prevent people from falling in the river. We don't have to save them down the road. They've stayed healthy and strong all along. We also need to build our systems, and we need to focus on child and family well-being throughout the counties, and the state. We know that access to primary prevention services actually uplifts everyone. So obviously there is a cost to this, but we know from our data that accessing primary prevention is actually a lot less expensive and much more beneficial than waiting until we have the need for tertiary services. And finally, we want to make sure that healthy, thriving families get support before their level of need escalates. We don't want to wait until families are in crisis. We want to try to give them the skills that they need earlier on. So moving things up ahead. All right, next slide. All right, so now that we've talked about these benefits of focusing on early intervention, early support, we're going to look at two frameworks of primary prevention. And keeping in mind here again, the ultimate goal is to strengthen families and improve community well-being. As we look at these two prevention frameworks, think about how you're already doing these things in your work. And again, as we said, you're probably doing a lot of things that already are in the primary prevention area. So be thinking about that as you're looking at that. We're going to do a very high level overview of these two frameworks, which are the protective factors and the social determinants of health. But before I do, I just want to first quickly acknowledge that this may be a refresher for many of you, or you may be familiar with one of them and not the other. That's fine. Caltrin has a lot of materials, particularly with regard to the protective factors, including a monthly series. I think we may be dropping a link to that in the chat. But if you're looking for more information, we can help you out at Caltrin. All right, next slide. All right, so I'm going to start us off with a quick poll. I'd like to find out how familiar people are with the protective factors already. So, could you, very familiar, you could name it, familiar, somewhat, or never really heard of this before. And it's okay, because we've definitely had a whole spectrum of folks. We've got people at all different levels attending today. And so I think that's really helpful. I'm going to give us, let's see, when we hit 80%, we're getting closer. Last few people. Okay. All right, last couple seconds. Looks like rates are slowing down. I'm going to go ahead and end it and share. All right, thank you. So what we're seeing is that the majority is familiar, can recognize them, can match, but we've got a lot of people who are also somewhat familiar. So we're going to give you a quick refresher today. And like I said, if you want really in-depth stuff, check out that link that we dropped in the chat. Okay. All right, so where did these come from? The protective factors framework was developed by the Center for the Study of Social Policy. Yeah, sorry, we're going to stay on this slide a little longer. And the goal was to create a systematic approach to prevention that would reach large numbers of children long before abuse and neglect occurred. The protective factors framework was designed to assist professionals who work with children and families in promoting the optimal development of all children while protecting vulnerable children from maltreatment. I'm going to give you a brief overview of each protective factor and what it means. And then again, as you're listening to these, be thinking about how you're already incorporating these protective factors into your work. All right, next slide now. Thanks. All right, so this first one, I think this image is perfect. So parental resilience. This is a definition of resilience from the Children's Trust Fund Alliance that I really like. And they define resilience, as the ability to recover from difficult life experiences and often to be strengthened by and even transformed by those experiences. So I think these palm trees in the wind is a great example. They come back even stronger. Resilient parents have empathy for themselves and are able to keep a positive attitude They can solve problems creatively, and they can take events in their life in stride. We would say they're able to bounce back from negative experiences. So resilience isn't just about the bad things you experience. It's really about how you respond to them. So very simply put, more resilient parents are stronger parents. Parents who are more resilient will be able to take good care of their children, even when they're experiencing a crisis. From a prevention mindset, strategies that providers can utilize to build parental resilience in their clients or their families could be responding to a family crisis by making referrals, modeling that, valuing and supporting those parents, encouraging them, ensuring that families feel welcome in the service process, and that families are involved in decision-making at all levels. So in the chat, I'd like you to drop in, what are things that you are currently doing that help support and build parental resilience? So if we want to drop a few, I know we had a bunch of people who are working in primary prevention. I know folks out there are already doing stuff. What are you doing to help build parental resilience? Parent cafes, thank you. Those are great. Those are kind of parent community networks where folks get together. They can be in person, they can be over Zoom. You can do lots of things. I'm going to see if other stuff comes in. Other parents get together to chat. Exactly. It's that peer building. You can also do things, parent leadership opportunities. Great. Supporting parents as decision makers, helping parents see that they have abilities to lead, to make decisions, build on strengths. Yes, exactly. Helping encourage parents to manage stress effectively, teaching parents some mindfulness skills, anything that you are doing that is helping, strengthening families. Yes, advisory boards, support groups. Excellent. So helping parents become more resilient is going to translate to parents who are able to parent better and more effectively. So thank you for folks who've been sharing that in the chat. Let's go on to the next one, which is social connections. So why do we consider social connections a protective factor? The Child Welfare Information Gateway defines it like this: parents with a social network of emotionally supportive friends. I think that's the key. Supportive friends, families, and neighbors often find that it's easier to care for their children and themselves. Most parents need people they can call on at least once in a while when they need a sympathetic ear, advice, concrete support, etc. And research has shown that parents who are isolated with few positive social connections are at much higher risk of child abuse and neglect. We know this is true. We all need people in our lives that we can go to for support. And we need positive social connections that help lessen our stress, help us feel like we're part of a community. And I think the key here is that it's positive and supportive relationships, because I'm sure we've all worked with families or, parents, children, whoever, who don't always have a positive social network. So we're talking about that here. So again, go ahead and feel free to drop in the chat if there are things that you are doing. I think some of the things that we just talked about, the parent cafes, these are all things, parent partner meetings, they're all ways to build this. So some strategies that we can take to build social connections include facilitating friendships, mutual supports, play groups. Yes. Get the kids together, get the parents together. You're building those networks. You're helping parents connect with each other and develop those positive social networks. And this is where I think family resource centers play such a key role, that they're bringing families together. They're providing these opportunities for parent-to-parent support groups, workshops, cafes, etc. And so if you're not familiar with family resource centers in your own community, take the time some point in the next day or so to look up a few of them and find out about what are those community services that they're providing to help build positive social connections for your families. All right. Third one is knowledge of child development. So let's be honest, some of the parents that we work with did not have the best parenting themselves, and they may not really understand the needs of their children and what's appropriate. We know from research that parents who have some knowledge of basic child development are more likely to have realistic expectations of their children, of their children's abilities and their behavior. And then with that knowledge, parents are better able to provide appropriate nurturing, appropriate supervision, guidance, and so on. So parents have to start with knowing about what their kids need and what's appropriate at which ages. When parents can understand their roles in their children's lives and learn about specific parenting techniques and strategies, they can help form better relationships, more positive relationships with their children, and have more options for appropriate response to really what are often typical child behaviors that are problematic. So again, drop in the chat, what are some things that you're currently doing to support knowledge of child development among parents that you work with? A lot of community-based organizations are doing this. I see a parent education program, Incredible Years, that's focused again on helping understand and respond to sometimes difficult child behaviors. It could be something as simple as creating fact sheets about child development stages. What's normal behavior in an 18-month-old versus normal behavior in a 5-year-old? And having unrealistic expectations. It's modeling developmentally appropriate interactions with children, providing guidance. So there are probably other things that folks are doing. If you want to, keep feeling free to drop things in the chat. But I think it's really providing that information in a way that's accessible to the families that you work with to know what is appropriate at what ages, and then how parents can respond when they're having issues in the home. All right. Fourth one, we'll go ahead and jump to that. Thank you. And this is concrete supports in times of need. So every family at some point needs help. It might be when a child is ill, a parent loses a job, etc. The challenges could be minor, but they also could be critical to the family's survival. And so we all at some time will need a lifeline for our family. If we help families find and access these essential sources of help, we're building protective factors against stress and in turn against possible child maltreatment. So we might do this by linking families to services and opportunities in the community. We could do it by responding when families are in crisis, helping families develop skills and tools to identify their needs. And I think one of the most important things we can do is provide information on resources available in the community, even if the family doesn't need them at that minute. So I know a lot of agencies use resource materials. So having those available so that if the family does need them and they're not comfortable asking you, they may already have access to some of that information. And then the last one is the social and emotional competence of children. Thank you. What you'll notice is that this protective factor is the only one out of the 5 that directly addresses issues with children. The others were all parent facing. So this protective factor really gets at the importance of helping children and youth become more capable of handling life's challenges, socially and emotionally as they grow. This is seen as their ability to communicate clearly, to recognize and regulate their own emotions, establish positive relationships with others, problem solve, resolve conflicts, etc. So these are all things skills that children typically learn as they grow, and that children who have these skills are likely to have healthier behaviors, better peer relationships, higher capacity to respond to stress, etc. So we really need to help children develop these skills as well to improve family relationships and hopefully prevent child abuse and neglect. Because we know that when children and families are getting along better, there's more enjoyment, there's decreased risk of maltreatment. So things that we can do, we can help parents of young children foster their child's social emotional development. So here you've got a picture where you have a parent, working with a toddler, talking about happy, sad. What does it mean? Kind of talking about emotions. We can model different ways to nurture. We can also help children understand cultural issues and how to interact with all different types of people. Okay, so lots of different ways. All right. So those were, next slide, please. Those were the protective factors framework. And now I'm going to give you a little bit of information about the social determinants of health. So this is another framework that helps organize prevention work. We're using the categories that were developed by the Centers for Disease Control. These are conditions in which you live, learn, work, and age, and they all affect your health. And so the social determinants are really non-medical factors that can influence your lifelong health and well-being. And the 5 categories we have here are educational access and quality, healthcare access and quality, neighborhood and built environment, social and community context, and economic stability. You'll notice that these are a lot kind of similar, but a little bit different from the protective factors. And I believe we're dropping a link, or we may have already done that. Thank you. That gives you, again, a little bit more information on the social determinants of health. We've had previous webinars that talked more about protective factors and social determinants, but this is just a little flavor. So what's the difference between these two? We'll go to the next slide. Again, two frameworks. They do very similar things, just a quick distinction. In general, the protective factors are more focused at the family level, where the social determinants of health are more at a systems level. But other than that, it's a way to organize what you're doing. And on that note, I think Kush, you wanted to mention a couple things here too. Okay.
Yeah. So the question becomes on the ground as we're doing as we're creating our service array, we're choosing which services to bring to bear to the target population we've selected. Which framework do I use? And we're gonna drop a link in the chat here to one of the tools that are in the implementation guide, embedded in the implementation guide that Dana referenced earlier. And my recommendation is use both. And here's how I recommend using both. When you're doing your gap analysis for primary prevention, right? Say your target population is children 0 to 5 whose parents have substance abuse disorders, making that up, okay? From a primary prevention perspective, I would do my gap analysis using the social determinants of health. Okay, what do I have in terms of economic stability for this target population? What do I have in terms of education? What do I have in terms of health and mental health access? What do I have in terms of neighborhood and built environment? What do I have in terms of social and community context, right? And you'll see what you don't have for that target population. Maybe you've got a whole bunch of economic stability stuff and very, very, very little education, right? So that'll give you your gaps, I assert, at the primary level. And then at the secondary level, using the protective factors framework to do the gap analysis, I think will work really well. So for that target population, okay, what do I have that engenders social and emotional competence of children for these parents of these children? What do I have that promotes parental resilience? Maybe you have a whole bunch of one and not enough of the other. Right, so I recommend you use both. You can use one; it'll work. But I think we have a chance here to really be comprehensive and hit all in the way we do our gap analyses. And so use social determinants of health as your organizing principle when you're doing a primary gap analysis, and use protective factors as an organizing principle when you're doing your secondary gap analysis for the same target population. Thanks, Jennifer.
Thank you. Thanks, Coach. So as a reminder, there actually was another webinar in the series that touched on gap analysis. So if you're at that stage and you want more information, please go back to the Caltern website and you can take a listen to that one as well. Kush covers a lot of these same topics in more detail. All right, so let's move to the next slide. Where do we start? So this is tier 1. This is the start. So we're talking about modifying the system to focus more on primary prevention. But how do we get there? The system always sounds like it's someone else's problem. How do we modify the system? Well, we need to work at different levels in order to be successful. We need to shift our individual mindset. So each of us, no matter where we are in this system, needs to think about what our own individual role is in this. We also need to shift the mindset of our organization. If you're in an organization that's really seen yourself as tertiary, how do you start building in the organization? Whether it's your mission, your vision, how do you start building primary and secondary prevention into that so that your whole organization sees that upstream approach as part of their job and not just the tertiary? And then lastly, community. How do we help community see and build that community collaboration that we need to prevent and not just respond, and that we need to shift our efforts towards primary? All right, so let's give a couple of examples. Next slide. Of things that you could be doing. So at an individual level, it's things as simple as getting educated, knowledge, understanding, thoughts about primary prevention. It's attending trainings like this one to hear about how your work can include primary and secondary prevention. And as was mentioned earlier, as Kelly mentioned, we have many webinars that have already been done that really talk about shifting to a prevention mindset and what is primary prevention. So it may be going and watching some of those, sharing those with your staff. So learning more about it. It's reframing. I used to think, my families were this, but now I'm wondering if it's this. So it's thinking about that different mindset and thinking more about the reasons behind the behaviors that we're seeing, for example, shifting upstream to get at how people ended up where they are. At an organization, like I mentioned, it's building that shared vision. It's reinforcing at an organizational level that prevention is part of your effort, and it's not just tertiary, it's primary and secondary. And that's going to be staff training and development, a lot of the things that we're talking about today, and I'll get to some details in a couple of minutes. And then at the community level, it's making sure that your comprehensive prevention planning team is really thinking upstream. What are the primary prevention activities that you can be doing in your community? What are you already doing, like we talked about in the gap analysis? And where are those holes? And then really making sure that your community is functioning well and all working together. You're getting involved with your CAPC, your Child Abuse Prevention Council. You're knowledgeable and you're including the Family Resource Centers, FRCs, in your community in this effort. So it's cross-system collaboration. All right, so next slide. Let's talk about what's really going to happen. So this is tier 1, the base level. This is prevention principles. So as Kelly mentioned earlier, as part of the statewide prevention plan, training will be provided that addresses a lot of these topics that we just covered. The first level of training, workforce development, let's start using that terminology, is going to focus on prevention principles so that we're all using the same vocabulary and we have a common understanding. These trainings are going to be broad and try to reach a lot of the workforce. We've been delivering trainings on these topics all year, and many of you and your staff may have attended them. So if you've attended the Reimagining Prevention series, you may have gotten a lot of this, but these trainings will be expanded and we'll be reinforcing those efforts through this workforce development plan that's coming out. All right, next slide. As you can see here, tier 1 has a broad audience. Primary prevention is a community effort. So we all need to be on the same page. It is caseworkers, supervisors, those Title 4E workers that Kelly mentioned earlier, but it's also the county and community partners, behavioral health, substance abuse, community-based providers, family resource centers, prevention networks, pretty much everyone. These tier 1 trainings will be open really broadly to the community. Okay, next slide. Thank you. What are the topics? 3 main things we're going to be covering in tier 1. Family First Prevention Services overview. And notice that it's FFPS. If you aren't familiar with the difference between FFPS and FFPSA, FFPS is the state's effort, and it actually goes broader than FFPSA. And so there is both federal and state legislation. We'll talk about the main elements that are required for FFPS, and then what are the roles and responsibilities of both staff and of those cross-sector partners. The second topic is shifting the mindset, a bit of what we just covered. How do we shift our perspective on our practice from intervention or tertiary to primary and secondary prevention, intervening earlier? We're also going to talk about the role of the community provider in supporting families. So I know we had FRCs that were on here. We had community-based agencies that are already doing primary prevention. We need you guys to keep doing it. And now we need to have you help the rest of us kind of move in that direction. Lastly, it's also going to be an overview of what some of you are familiar with, the integrated core practice model. And so for those who are not familiar with it, it's making sure that you're all getting the basics of what that model is and why it's important as for service delivery. Okay, next slide. And then the last topic area, and this is a very important one, is a recognition that we need to address implicit bias and the inherent disproportionality in the child welfare system. We need to understand how implicit bias affects our own work and practice. We need to understand the data on disproportionality. What do we know about how that data is contributing, how it's affecting our marginalized populations? And then lastly, how to identify and assist families with accessing culturally relevant services. Okay. how will this training be provided? It's going to be developed at the state level, as Kelly mentioned. There will be training for trainers, T for T is available. Our Title IV staff will continue to be trained through their usual mechanisms. So RTAs, where you get your training currently. Community-based providers, you can go to the next slide. This is a little bit to be developed because every county's plan is going to be unique. So how we're going to train community pathway providers may be a little bit different in each county. But in general, we will have statewide training, webinars, large group trainings like this. And then there may also be, or will likely be, some individual county responsibility with that goal to build capacity to deliver training for sustainability purposes at the county level. So more to come on that county piece. And then last slide, timing. When is this coming? It's going to depend a little bit on contracting and capacity, but we're aiming to start delivering these services in the middle of 2023. So with plans due in January, after that, we'll have more information about how to roll this out. Okay, I think I'm passing this back to Kush.
Indeed, for perhaps what may be the most entertaining part of the presentation for most folks. Welcome back, everyone. We are going to get back to our conversation about the tiers, and we're going to move to Kelly Winston and tier 2. Hold on one second, Kelly, while I get Sharon. And there you go.
Okay, so again, we're going to be talking about tier 2 for the foundational skills. These are for direct services staff. If you want to go to the next slide, Kush. Great, thanks. Okay, so we wanted to share with you today, and you're probably going to hear us say this type of information a few times just to help make sure that we get the direction, the thinking, and the point across. So Jennifer may have said already some of these things, and you'll hear me say them again, but I think they're worth repeating. So we wanted to share and focus a little bit on the initial proposal for the curriculum development and plans for training delivery of the foundational series. Again, this is what we're calling tier 2. And tier 2 is broken up into 2 different phases. Again, we want to be able to do as much training as possible prior to the development of the CWS CARES, and then those aspects of the training that need to be delivered when the automation is available will be that kind of once we're talking really more about phase 2, so to speak. So tier 2, phase 1, I guess we'll call it. So prior to CWS CARES is really to help focus on the knowledge and skills that are necessary to engage families earlier in the system or before the system contact, get those staff ready to deliver evidence-based practices and do those case management activities so that we're consistent with federal requirements and then consistent with the vision in the state's prevention plan. So CDSS has been working with our training partners to determine how best to deliver and develop the curriculum that will prepare this local workforce, really keeping that prevention mind shift in context with all of the training that we'll provide. These next couple of slides will reflect on some of the training proposal aspects that are currently under development. So this work is in the beginning stages, and there will be opportunities for you all as stakeholders and service partners to weigh in on what is needed. These slides represent our initial conversations about how to roll out this workforce development approach and what we think we're going to need to accomplish that. The examples that are shown on this slide are focused on engagement, assessment and service selection, understanding the availability of EBPs locally, and of course, information about eligibility determinations, including the difference between a candidate for FFPS services and others who are eligible to receive those services, such as family members of candidates and foster youth who are pregnant and or parenting. Tier 2 will further dive into details required for the family-specific prevention plans, how a Title IV agency or a community-based organization may need to work with a tribe if they're serving a tribal member who is eligible under ICWA. And when appropriate, understanding the criteria for determining the length of services available to each family, because that coincides with that assessment of imminent risk. And then ensuring that child safety and periodic risk assessments are skills that those staff have. Finally, this will also cover monitoring and transition planning, and all of the elements you see here are within that training proposal for how services will be delivered. We anticipate that most of these training elements will be ready for delivery prior to when counties begin delivering their EBPs. But again, we want to do this before automation is available so that it's ready to go as soon as the system is up and running. Next slide, please. So this next phase of training, again, will coincide with CWS CARES. There are aspects of the Family First Prevention Services program where automation is really needed. So the training on these elements will be done in context with the rollout of CARES. So you may see training that looks more like just CWS CARES training, but much of it will need to be focused on how it interplays with the Family First Prevention Services model. So this is going to include requirements for documentation of family eligibility, determining the determination of candidacy, and ensuring that we capture compliance with the Indian Child Welfare Act where appropriate. It's going to cover documentation and data entry for family services prevention plans, and that data that's required for federal reporting for the fiscal elements of those requirements. And then also what we need to capture for ongoing monitoring, that safety and periodic risk assessment, and then the length of services and transition planning for once a family is ready to end their FFPSA or FFPS program. Next slide, please. So I think one of the big questions we all have is that logistically, we need to figure out how to make this happen. And in order for all of this training to come together, we're working again with all of our training partners across the state. This, as Jennifer mentioned, will include many of our usual county training partners, such as the regional training academies that includes Los Angeles County and their training bureau, the chief probation officers of California, as many of these entities are some of our main direct staff trainers for those entities. But because FFPS utilizes a community approach to service delivery, we've also invited many of our additional training partners who can help with those who will be more instrumental in the community pathway. So for example, the Resource Center for Family Focused Practice and Caltrin, who you see here today, are likely to be some of our training partners as we further this proposed training plan. Tier 2 will likely have a primary curriculum that ensures consistency of those foundational skills across the state and the ability to ensure that we are meeting all of those federal requirements and the vision that we've proposed in the 5-year prevention plan. This is really to ensure that well-trained professional workforce. In addition to this, we have this primary curriculum that will be adapted for each audience to ensure it meets the needs of their role, whether they're a child welfare worker, a probation officer, or a community pathway provider, someone providing services in a tribal community. We want to make sure that that primary curriculum has those nuances to meet all of those needs. At CDSS, we do intend to invest a considerable amount of our resources in the curriculum development, and potentially, depending on what resources we have once that curriculum is developed, we may be able to do some training for trainers or T4T kind of approach to help ensure that that curriculum is available throughout the state. We intend for this primary curriculum to be developed by one entity with input from their training delivery partners to support those nuances needed for each audience. In discussion with our training partners, we're figuring out who is going to be best positioned to lead that work. And counties will be able to tap into both Title 4E training funds as well as the Family First Prevention Services state block grant money to support the local training needs and meet those additional needs beyond what the state can provide. We know the timing of this curriculum and training delivery depends on a number of things. CDSS is currently working to develop or amend contracts so that we can quickly man each of these organizations or ensure that they have the resources needed to develop and deliver training. And the contracts that we are looking at, may also go beyond just basic training and include potentially some, other types of support resources so that there can be that continued support for counties who are trying to implement the programs. We want to make sure that we are able to meet some of those specific local needs, knowing that training, the organization of training and support beyond training looks different depending on where you are in the state and how your county system is organized. So the timing of these contracts and the development of the curriculum and the availability of cares, they all play a role in when all of this will become available. As Jennifer said, we're looking at, once prevention plans are completed and turned in, we'll start that process for development of the curriculum and then rolling out trainings as early as spring and summer of 2023 if all the stars align and we get all of these contracts available, that's when we're hoping to begin that type of training. So tier 2, that first phase, will be following the completion of tier 1, and then the second phase will be aligned more with the implementation of CARES. So some of these dates are our best guesses at this point, and some of them may be a little optimistic, but we want to time them in such a way that we're delivering training in a way that makes sense so that your staff aren't getting it too early, and so that they're also timed with the rollout of the system so that we can actually begin delivery of the EBPs.
Thank you,
Okay,
Kelly.
I think back to you, Kush.
Yes. So now we've heard about the kind of training that is contextual, has folks shift their context, and is applicable to anyone who has any function inside of a comprehensive prevention services system. We also that was tier 1. We also heard about tier 2, which is targeted at the casework and the administrative functions that are going to be required so families can get the right service to them. And then there's going to be, these caseworkers are going to be creating these prevention plans. And these prevention plans are likely going to have EBPs in them, right? And so Dan's going to talk to us about what does EBP specific training look like inside of this workforce development system. We're calling that tier 3. And what does it look like for practitioners? Because you have to remember, EBPs train practitioners, right, to practice that evidence-based therapeutic program. There are organizations that hire those practitioners, right? So there may be some economies of scale available that way. So Dan's going to talk to us about that world and how it pertains to what we're up to here in California.
This other world of
Yes.
the tier 3 planet. That's right.
Yes.
Good to talk to everybody again. I was glad to be a part of the last conversation. You may recall we talked about fidelity and quality and those kinds of things. So, backing up a little bit from that, I guess, is this idea of introducing training and training approaches that are EBP specific. So let's go ahead and look at which EBPs we're talking about today. As you all probably know, there are 10 that were selected as part of the statewide plan. By the way, I'm going to try to keep this short, but I'm going to talk about the types of EBPs. I'm going to talk about the types of training, the levels of training, contracting approaches, and then a little bit at the end about philosophies. So there's kind of 5 different aspects of this training that I want to talk about today. At the bottom, let's highlight that first. It's just, it's almost as though folks got together and said, let's figure out the most complicated, confusing, complex way that we could do this. Let's everybody do it differently. Let's all, let's all make sure we don't do it the same way across the EBPs. Of course, they didn't do that, but sometimes it feels that way. So everybody's approach to training is different. Whether they, there may or may not be one purveyor, or there may be multiple purveyors or training organizations. They might offer discounts for training based on one particular strategy or another. They the way the training is rolled out is different. But I'm going to talk today about as many of the common features as I can to try to help you guys navigate this planet. Brief strategic family therapy, we're going to talk about that as one of our examples later on. Is one of the well-supported models that actually crosses all 3 of the domains, the in-home parent support training and substance abuse and mental health. Family checkup recently added, but as many of you know, it's one of the models that actually addresses almost the entire age group, from little ones to older adolescents. Functional family therapy, and then I'll jump down to number 7, multisystemic therapy, are well-known EBPs for adolescents, in-home therapies. Healthy Families America, Nurse Family Partnership, and Parents as Teachers are under the class of EBPs called home visiting programs. And so folks, especially in the Department of Health or Public Health, support those kind of programs for early intervention. Home Builders is a crisis model designed to immediately go out and prevent, whenever possible, the need for system intervention or removal. Motivational interviewing, as many of you know, is a more generic, let's say, model of interviewing and talking with clients aimed at increasing motivation to pursue treatment and participate in care, that could be applied across a wide range of topics and issues. And I guess PCIT is the only one I haven't mentioned yet. Parent-child interaction therapy is a very well-known evidence-based program for the 2 to 7 age group. So takeaway point here is that there's a wide range of EBPs for a wide range age groups and issues, and that each EBP will do their training just a little bit differently. So let's get into that. So what I think you'll notice in the training as we get into more of the details is that the training or purveyor groups. Purveyors are folks who do training, they do licensing, and they do ongoing coaching, and they are in charge of quality assurance. So I'll use the word purveyor to cover that group. There's a lot of literature and learning that's been going on over the past 20, 30 years about the old-fashioned way of training really doesn't work. And many of you and I have participated in this old-fashioned approach, right? The half-day training, the binder. We used to get binders. Now we get whatever, flash drives or something. But then, you go back to the office and you try it out. And that approach is sometimes called training and hoping or spraying and praying. But there's a lot of literature suggesting that people go back to the office and don't implement as it was intended. And you kind of have this experience of doing some of it, and some of it seems to work and some doesn't. So you stick with the stuff that works and you sort of adapt as you go. And it really doesn't lead to much change in practice, certainly not across a team or organization or county. We're all kind of, taking a one man or one woman approach to it. But we do all end up with nice binders across our shelf, that shelf of shame of all these binders that, remind us of what we should be doing. Okay, so we're trying to move towards a better way of doing things. And so the more modern view is to approach training and coaching and QA and licensing as a package. And so, you can put yourself as a relative, newbie or neophyte in this EBP world and put yourself in the training and really feel surrounded and supported, not just at the orientation level, but a lot of the models provide weekly or monthly coaching. Some of them require that you audio tape or videotape your experiences and then give you, coaching and supportive feedback around your working with your actual clients. And by the way, that, you may disagree, but a lot of these models will say, even the best tennis players and golfers in the world have a coach, right? We can always, even if we're at the top of our game, we can benefit from the consultation and feedback from an expert. And so the models are built around these ongoing coaching relationships. And while the requirements may vary, in general, purveyors have guidelines about who can get trained, what level of education or certification you have to have, how training is done, how long it will last, and how the training and coaching relationship is sustained. It's never a one and done. Probably the biggest takeaway for counties today, I think, is to recognize that when you enter into a relationship with any one of these EBP training organizations, it's not just a first year and we're done, right? It's an ongoing commitment to EBPs. I think part of it now, we're living the reality of a high degree of turnover, maybe 25-30% on average turnover in the mental health field. So if you have 3 or 4 or 5 people on a team, every 3 or 4 years, you have a brand new team, right? So it makes sense that this relationship would be ongoing and be able to sustain that kind of turnover. And the licensing, third point here, licensing is often dependent on providing some sort of proof that the program is being delivered as it was designed. If you will, protecting the integrity of the program. You don't just adopt, FFT and then do whatever you want. You have to actually do FFT the way it's intended. There are some economies of scale, different kinds of ways of offering discount depending on training that might reduce over time, sometimes a little bit, as the team demonstrates fidelity and the amount of training and support that's needed. There may be a discount offered, or it may be a discount based on scale. If 2 or 3 or 4 programs train together and do their boosters together, sometimes there are bulk discounts, so to speak. So that's a longer budgeting conversation. We can have that another time. And fortunately or unfortunately, I don't know, the reality is that there are usually often more than one training purveyor. I shouldn't say often, about half the time. There is either one single purveyor that provides training in, for example, MST, or sometimes there's 2 and sometimes there's multiple options. And I'm going to give some examples of each of those today. All right. Now, let's go to the next slide. And I hear people often ask about capacity building. And so let's talk about that just a little bit. What do we mean by EBP capacity building? If your county wants to build capacity in, say, parent-child interaction therapy or motivational interviewing, what does that look like? Across the different EBPs, there are different kinds of capacity building, different strategies towards building in-house capacity. The one that people are most drawn to, and we talk about train the trainer training number 6. How do we get to the level that we can have our own experts in-house? And I would agree that's lovely, and when that can happen, that's great, and we want to support that. That doesn't obviously happen overnight. I think that most of the time, the best experts, train the trainers, come up through the ranks. They have real world experience. They know the model. They know it's been implemented in that county. So that's a 2 or 3 or maybe 4-year commitment, to the model before we get to that level, in my experience. But the other, more relevant and front door kind of training strategies, obviously there's some way of introducing the model to the community. Sometimes it's called a stakeholder orientation or introduction, community introduction. There's introductory training for the clinical team, the practitioners that are actually going to deliver the model. What about supervisors? I would argue supervisors are the key perhaps the most important link between the expert, wherever they are in Utah or Colorado or New Jersey, to the on-site, implementation, the provider agency that's delivering the service. The supervisor is that key person. And so how are they trained and supported? Booster training, ongoing, quote, continuing ed, addressing evolving or complex needs of complex families. There's the whole quality assurance training. How do we collect fidelity measures? How do we report them? How do we interpret them? And as I mentioned, train the trainer training. And of course, again, if we do have 30% or so, statistically speaking, of our team turning over each year, how do we replace those people? And so, again, a lot of different layers to that relationship. All right, so just some examples of the, as you get ready and you think about engaging in Tier 3 and in connecting with one or more of the purveyors, just a note to say that sometimes you'll find that there's only one purveyor and sometimes there's more than one. And so just know, I don't know, I always use analogies and then they fall apart on me, but car shopping or something, there's more than one dealership to visit, or there's lots of models out there. You really have to know kind of what you want. And then when you get there, you test and see if you can find what we're looking for. But with Nurse Family Partnership, there is only one. As with MST, there's only one. And so the National Service Office in Denver, Colorado is the place to go for training in the NFP model. And then just a really quick blurb about, their different levels of training and kind of an intro to how things work. As many of you know, one of what's unique about NFP is that they hire and train and support nurses. So your team is primarily made up of nurse home visitors and nurse supervisors. And those are the folks that will be participating in the training. Okay, next slide. So then I think we're going to look at BSFT. Yeah, so brief strategic family therapy, which I mentioned earlier, was one of the 10 on the list. There's actually 2 purveyor organizations. They're both in Miami. They're both related to the developer of brief strategic family therapy, BSFT. His name is Jose Shapoznik. And this is a model that was developed originally for Spanish-speaking families with kids that were getting involved in either drugs or in the juvenile justice system. But there's 2 different training organizations that you may end up contracting with. Either one is fine. It's just a matter of calling and figuring out who has, an open space on their dance card and can work with you and contract with you. And but you might want to talk to both. They both train just a little differently. Here's an example of their training formats with the Family Therapy Training Institute of Miami. There's this 3-day initial workshop, etc. If you can show the next one, Kush, option 2 is also in Miami. This is based at the University of Miami. This is the Brief Strategic Family Therapy Institute. And so, again, this is from their website, the 3-day interactive workshop followed by regular group supervision. And I underlined the part about the BSFT model manager provides feedback on DVDs or recordings of actual family therapy sessions. So that's a cardinal requirement of the QA system with BSFT. So really, really hands-on coaching and support with that model. Okay, the last one, which you've all heard about, is next slide, is the motivational interviewing. And so some of you have already gone down this path and you've started working with a Mint certified trainer, the Motivational Interviewing Network of Trainers. And Mint certification is the key here. But whereas with Nurse Family Partnership, there's only one purveyor, with BSFT, there's 2. With motivational interviewing, there are literally thousands. There's at least 60 currently on the Mint certified motivational interviewing trainers in California. And their philosophy is a bit different from, say, Nurse Family Partnership, which is that the guidance on the website under the category of what you might expect out of the different lengths and types of training suggests that, down here at the bottom, the onus of responsibility for ensuring that you get what you pay for is on the buyer. So you've got a lot of responsibility to interview different trainers and to see who you think is providing the best training and who's committed to delivering training with fidelity and coaching and support. This is a great example of, please, please, please just don't go with the cheapest car on the lot, right? We all know what that is like. And so, this is not about cost, this is about quality. And so buyer beware. So, of course, last slide for me, I think, is this notion then of what I call the control issues. With the evidence-based programs, I think you'll, as you get into this and as you look through for your county, the different EBPs that you're interested in, and then once you've selected EBPs, talking with the EBP purveyors or training and licensing groups, there are different philosophies. A continuum like this might be oversimplified. But on the left, I think you will find that some of these purveyors really take responsibility for training, fidelity. Like if it's not being delivered as a high fidelity version of the program, then they get really upset about it. And they really want to, organizationally, professionally upset. They want to intervene. They want to work with you to try to figure out how can we get the team to fidelity. That's the most important thing. At the other end is that the onus of responsibility for fidelity is on the end user. And so we provide training, and then it's kind of up to you to figure out how to make it work in your community. I think there are strengths and challenges in both approaches, but you will find that you may be surprised sometimes at the level of detail of support and training and guidance that's provided by some folks, and conversely, the lack thereof from others. So just a kind of a heads up around that. And that's it for now.
All right, welcome back, everyone. Glad everybody enjoyed that particular timer. Caltrain has some really great ones. Much appreciated. Okay, so let's start to get to the wrap up of the conversation with some closing reflections here. And we have some inquiries of you that will sort of help the folks on either folks on this webinar listening help plan what kind of information you need going forward. So here we go. Okay, so before we get into some polls and Q&A, I want to close the loop on the conversation we started with what are the elements that go into this domain, this workforce development domain. And we're going to talk about the other side of that, which is, okay, so how do you know you're ready with regard to having those elements well enough in place so you could start delivering services? Okay, so this is how I would answer that question. So first, you have to have identified and documented, and you being, there's CDSS will have to do some of this, the counties will have to do some of this, the EBPs already have done this, but identify and document all the practices, the mindsets, and the administrative functions which you're going to require for the delivery of services in your chosen service array. So what's all the training content, Tier 1, Tier 2, and EBP specific, that you're going to need, and where is it? Okay. Then you've identified the training partners, and some may be it may be as simple as your RTA, and allocated the appropriate funding to provide training and coaching on all tiers. Again, this applies just as much to CDSS as it does to the counties. You've completed conversations, or almost completed conversations, with all your training providers regarding strategy and sequencing and scheduling to train staff regarding all areas, right? How will you train existing staff? What will happen with ongoing training or booster training for new staff? Do you want to, when do you want to do this, the stakeholder orientation as relates to the T for T? All those kinds of questions about strategy. Then You've drafted and agreed upon statements of work with training providers with regard to training staff. So you've got the strategy, and now that strategy is manifested in a contract and a statement of work that's signed and ready to go. Those are long poles in the tent, and we all know sort of bureaucratic contracting can take a while, right? So some of these conversations probably have to start now and have a long ramp. And then you've written all of this and documented this in a training plan and schedule that is accessible, right, to your governance group, to your stakeholder groups, to other governments that you're talking to, such as the sovereign nations that are the tribes, that you've got something that you can point to that says, here's our plan, here's our schedule, here's when we'll revise it. And here's where to go if you have questions. So those are all things that have to be in place if you have a shot at delivering service well from well-trained service providers, right? You also have to train on business processes. It's not just the practice, right? It's the administrative functions, like Dan was saying. How are you going to do your data collection? How are you going to do your quality? That all is part of the plan and schedule. So that's what I would say would need to be in place for you to be ready to deliver service. All right, so let's now go to we're gonna ask you to fill out a poll. Okay. So the poll is, and here's a refresher on the EBPs that are currently in California's 5-year plan to ACF. Which well-supported EBPs are you considering? Sort of give folks a pulse on what the front runners are, and if there were economies of scale available. I'm not saying there are, but where to focus. All right, keep going. We've only got 37%. Keep them coming, folks. Favorite EBPs, looking like these are the ones we want locally. Okay. All right, keep going. We only have 50% of folks answering. All right, we should have probably put a don't know, now that I'm thinking about it, as I'm wondering if the rest of the 50 don't know. All right, keep going. Few more, come on, few more, folks. All right, our poll is slowing. So let's go ahead and close it. And let's share the results. Okay, so what does it look like? Well, it's not surprising that motivational interviewing is being considered by 80% of the folks that answered, followed by FFT, it looks like at 32%, and PCIT at 24%. So those were the big three. All right. So we have one more for you. It's a slightly nuanced question. So this question, so let's go ahead and stop sharing that one. Do I do that? Okay. Let's share the results. There we go. Okay, so I'm going to close this poll. We have another poll for you. Let's go ahead and put that up. This poll is which well-supported EBPs, folks, we need to relaunch that poll. I think I closed it. Nice. There we go. This is the second poll. Thank you. Apologies, folks. Which well-supported EBP do you need to hear more about to make your plan decision? Right. So this is not what are you considering or what do you want? This is what do you need to hear more about? Right. Because if we were to do some statewide or regionalized information sessions on EBPs, for instance, right? Who would we be calling to come talk to you? Keep going. 30% of folks have answered. All right. So different breakdown here, which is interesting. Sounds like folks have heard, while motivational interviewing was 80% being considered, sounds like folks have heard enough about it to know that they want it. On the other hand, family checkup folks want to hear more about family checkup. Folks want to hear about FFT. There are the folks that do want to hear about motivational interviewing, just not as much as who know that are going to adopt it. No. All right, we have about the same amount of folks who participated, so let's go ahead and I'm going to end it. Here are the results. So it looks like the winners are FFT and motivational interviewing, functional family therapy and motivational interviewing, with brief strategic family therapy and family checkup close behind. All right. Thank you all. So this will help. This will help those of us that might be able to bring purveyors to you do that. All right, thank you. I'm gonna close this now. All right, so now we're gonna move to our open Q&A part of our session. And as I mentioned before, we're gonna have some questions that we already had collected from our registration and over the course of some of the past sessions that were related to training, and then we'll open it up to the floor. All right, so I'm going to stop sharing so we can see each other, and I'm going to ask the first question. All right. First question, what are, and Kelly, I'm gonna ask you to answer this one. What are the training requirements specifically for staff completing candidacy and monthly safety assessments?
Great. Yes, thanks. So, I'm hoping that through today's presentation, you've heard a lot more about what the training expectations are going to be and what the training is intended to include. We did try to make that clear to you all. And so hopefully today helped to further that understanding. And then I'll just remind folks that more is coming regarding this specific material that will outline the requirements for things like documenting candidacy, for how safety assessments will need to be conducted, and you'll see more of this once curriculum is developed. You can still read a bit more about how, for example, candidacy is going to be assessed and what that safety and periodic risk assessments will be expected to look like in the 5-year prevention plan draft that was dropped earlier in the presentation. And then hopefully you'll be able to participate in some of the conversations that we're going to be having about training curriculum and training delivery as we work with our training partners to reach out and have those conversations.
Great, thanks, Kelly. And while you have the floor, sort of follow-up question, at least for tier 1 and tier 2, and then I'll punt it to Dan for tier 3. How are funding sources going to work? I know this is on everyone's mind. Who's going to pay for what, and what's going to pay for what?
Right. And so again, I mentioned a little bit about this in an earlier part of the presentation, but CDSS is investing in the curriculum. So that primary curriculum that we really want to have available and how that's going to be tailored for the different audiences. So we're going to be working with our training partners to create and fund that. And then we're also thinking that we'll be able to do to support the development of a T for T model so that individual counties and tribes who want to participate in that training model can access that T for T model. But then there will also be some need and expectation that local agencies use some of their state block grant or draw down their Title IV dollars to be able to support the training needs at the local level. I will just mention that while Title IV-E reimbursement is not quite yet available, once the prevention plan is approved by the Administration of Children and Families, we anticipate that counties will be able to start claiming those admin and training dollars that are available, and they'll be able to back claim probably all the way back until October of 2021, which is when we became in compliance with Part 4 of FFPSA, which allowed us to actually go ahead and expend Title IV monies. So that'll be the way that counties and tribes with a 4E agreement with the state can actually draw down those funds. And then if you're a community-based provider, you're going to be able to access those funds through the contracts that you have with those local agencies. So there's some, paperwork that will have to be kind of in place for that to happen, but it's certainly available.
And Dan, while, you may not have a very a California specific answer, because we've got a lot to iron out with regard to how EBPs are going to be funded, and might there be one that is really popular, and then who would are there economies of scale available? We've got to figure all that out. But in terms of what you're seeing as states are starting to implement their prevention, implement FFPSA, is there anything to share about how EBPs are starting to be funded? And what are you seeing?
Yeah, so we know that Kelly's answer was a good one. We know that we've got some details to work out. We know that folks who are families or children who are Medi-Cal beneficiaries, and some of these services fit within existing Medi-Cal categories and so forth. And as the EBPs are rolled out, Title IV requires that we get what we can by billing Medi-Cal, and so that's an important first step. And then Title IV picks up, from there. So that's an active, conversation in California. In other states, every state's doing it differently. I think the biggest takeaway so far, folks should plan on, let's just say ballpark, about a year of planning and preparation to deliver one of the well-supported EBPs. It may not take that long, and maybe some of the counties can, move the bureaucracies along and the paperwork along and the contracts and procurements along quicker. But it's probably safe to bet that as you identify your training and licensing organization, as you may have to procure for that, if there's more than one, as you settle in on that, and then you settle in on your same process to select providers, perhaps, then the providers need to hire and train staff, right? So and then you want to have a pretty strong plan for implementing and informing stakeholders who are going to provide you with referrals. All of that takes about a year. One of the places that I'm working, not to call anybody out, but they sort of tried to jump it forward a little bit and have been stuck with not having done the preparatory work. And so they offered the training and they started pushing it out, and then they've either found out that, there's not staff available to be trained, or there's not referrals to fill the programs. And so we've had to kind of start over a couple times.
Yeah, I can imagine you don't want the training to be too far away from when they're actually going to use it. And so
Exactly.
that also, we've got some local conversations to have about sort of what's the right time to train on EBPs with respect to when we're able to actually, claim for child-specific services and automations ready. So, those are local conversations we still need to have, but you teed that up well for us, Dan. Thank you. Right. Next question. Let's see. Okay. As a county using CBOs and tribes as part of our comprehensive prevention plan, how do we move toward increasing and developing their workforce to do this? So CBOs and tribes, keeping families out of child welfare services and the children out of foster care. So Jennifer, maybe you could answer from the tier 1 perspective first.
Sure. I mean, I think the tier 1 trainings are kind of how we get that broad information out to the workforce, whether it's the, county, the CBOs, the tribes, et cetera, to get that information about primary prevention moving upstream out to them. So as we mentioned, some of those are already available. Caltrans been delivering these, other folks have, and you can access recordings of the trainings, all the materials through the Caltran website. And then we'll be offering these tier 1 trainings that'll be rolling out in 2023 that will be widely available for these folks.
Great. And then, Kelly, what would you add? What would you add from the more sort of 4E and community pathway side? Oh, you're on mute, Kelly.
Thank you. Sorry about that. So similar to what Jennifer just said, I think, it's important to make sure that you're involving those staff, and if your tribe is an active partner in the development of your comprehensive prevention plan, you really want to engage them in discussions about how training should look of their workforce. Super important to partner with them on all aspects to make sure that it meets their needs, and to make sure that as we're thinking about how the Indian Child Welfare Act applies, that is something that is integrated into part of the training. And then I'll just fall back again on, the answer I gave a few minutes ago. The way that you fund all of that is obviously through that Title 40 eligible claiming, and the state block grant can help support additional training that needs to happen in order for those things to really be realized. I think that's it will take a lot of hands in the pool of the work that needs to happen to make sure that we meet those goals.
And there are a couple of questions in that we got today that are sort of relevant to this particular conversation, so I'm gonna bring them in now. So one, this is as much a suggestion as it is a question, but I think it's worth getting it on the mat. Will there be safeguards and training in place, right, for the community pathway and the 4E agency candidacy determination curricula? So we make sure we train folks so that we don't have unintended consequences of bringing more families into the system, right? So that being part, that philosophical content also being part of it, and also how community-based organizations, right, can position themselves, right, so they're not dismissed as an extension of the system by families who will then refuse services. So, I mean, anything Jennifer or Kelly to sort of say about that? Go ahead, Kelly. You're nodding. I'll let you go first.
Yeah, I mean, I think we've had a lot of conversations about what that will look like, and we want our curriculum to reflect that kind of thinking. We really had to balance the expectations from the federal government to monitor safety and to ensure that the Title 40 agency has oversight of the community pathway. So, we're really trying to come at that from a number of different perspectives. One is training the workforce to really be thinking about how the EBPs themselves address the needs of the family without prematurely contacting the child welfare agency. And then we also want to be thoughtful about the type of oversight that the Title 40 agency will have of those community-based services, and how we can use automation to help keep sort of like a barrier between the services until there's actually a threat of safety or a really concrete risk where the child welfare agency needs to be involved. And so that will all have to be incorporated into that curriculum. And then, really making sure that we have the supports in place post-training. And we know that training is not a one and done. And I've seen that through some of the comments here today. And we have to think about what those supports ongoing will look like.
Yeah, great. And I was going to bring I was going to bring that one in also. So, you know, and Jennifer, have you sort of talked to us about that, right? There, you know, it's not as easy as stating, you know, like, oh, we need to shift a mindset, right? And sitting in a class isn't going to shift a mindset, right? So just anything to say to folks about like how training is a lever, but what, you know, what are other things you have to do also? Oh, and you're unmuted.
Muted. Sorry. I think it's key to, you know, this is the tier 2 training. This is ensuring that all folks who are working in this area really understand that the goal of this community pathway, of this whole plan, is to keep families out of the system and to provide them those services they need, you know, so that they're not falling off the bridge and into the river. So we're really making sure that, you know, it's the training. And you're right, when we have turnover, it's how do we retrain people? How do we ensure that we're all on the same page with the goal of we're trying to keep families out of the system?
Yeah, and you know, something I'd add from like the implementation view, because you know, training is always, you know, implicated in implementations, and it always throws implementations off for the most part. So we won't be alone. But there are, yeah, there's the you should do this, right? Then there's the what happens if you don't, right? And that's where policy is going to have to come in. That's where supervision's going to have to come in, where folks aren't actually delivering service inside of the new mindset. They are saying things like the apple doesn't fall far from the tree, for example, right? So they are displaying some of those old views of thinking. And so there's always that part of workforce development that we don't quite put in place, because we assume everybody's going to do it. But that's not the case. And so then what are the safeguards in place for when it doesn't happen? So that's what I'd add to that from the implementation side of the house.
And Coach, could I also add
Sure.
that I think that, you know, we talked about CQI during our last meeting. You can look at your data to tell whether or not the mindset and culture shift in your organization and in your community is taking place, right?
Yeah.
You can begin looking at your disproportionality rates. You have a baseline of where you're trying to go and decreasing disproportionality, ensuring that services are getting to the communities where they need to go. That can be looked at through data. It's very objective, and you can determine the shift of your culture based on just looking at your data. And what you do with it, I think, then lands with your supervisors, then lands with training again, then lands in engagement and getting the feedback from your communities and the impacted families about what's working and what isn't, and working with your CBOs to ensure that those services that were intended by the plan that was devised by hopefully the agencies and the communities is doing what it's intended to do.
Yeah, and that's a great point. And so you got to be focused with regard to your target population, focused with regard to geographic boundaries, so you can actually see, like Dana's pointing out, that you're moving a needle, right? Because looking at disproportionality in the state, it's not going to tell you if you're moving your local needle, right? So how are you going to cordon that off and look at it? It's a great point. Thanks, Dana. Okay, so then next question. And, you know, we answered this when we were talking about model fidelity also, but, you know, it bears bringing up again in the training context. What are strategies for smaller jurisdictions or counties? Counties that perhaps are more rural, that may initially lack clinical capacity to deliver those specific EBPs. What are some strategies for training with regard to that? I'll let Dan answer, and then I'll remind folks that we've had some folks share in past sessions about this. Dan, what would you say?
Yeah, so this was specific to tier 3 anyway. And these these well-supported EBPs. So yeah, first of all, let's acknowledge it's not easy. Figuring out how to deliver these services in rural or remote locations is a challenge. It can be done. We've seen it done. And I think people are, a bit more comfortable doing at least a few things virtually, or, in a pinch. It's never ideal, but there are ways that some of the services we could leverage telehealth resources in ways that we didn't know that we could do before. But no, I think, as you might guess, many of these EBPs, the level of training and requirement support that's required, it's probably going to require cross-county or regional collaborations to figure out together with others who have similar needs and have identified a similar population, that you join into some kind of an MOA or MOU or intercounty agreement to implement, say, PCIT.
And we have information from counties where a smaller county, saw that a larger county was providing this EBP training and asked to participate. And, I don't know the details of the negotiation, but that did end up happening, right? So there are ways to take advantage of the economies of scale, where, I mean, they're flying the folks out, right? You could just get a slightly bigger room. So yeah.
And to the workforce issue, I think too, we do have experience where it's, you have a rural county somewhere or community, and it is hard to find a bachelor's or master's level, bilingual therapist, and counties have been mindful of that from the very beginning and have figured out a way to incentivize or build in a different sort of salary structure that would attract folks, ideally from that community who maybe went away and got their master's degree in social work, and now we're trying to encourage them to think about returning home and delivering that EBP back where they grew up.
Great. Thanks, Dan. Okay, let's see. Kelly, I'm going to ask you this one. Is the expectation, and then if there's a implicit question inside of that, which is, and how, is the expectation that counties integrate the state trainings into the CPP, right? And their development plan into the CPP? Like, how's training going to be reflected in the CPP, I guess?
Yeah, that's a good question. So many of you have been waiting for CDSS to release the CPP template. And part of the CPP template will include a number of assurances that counties and tribes may sign to basically state their intent and commitment to follow the plan that the state lays out. So we have a number of those assurances. One of them is workforce training and development. And part of that is because, we're still in the process of developing what that curriculum will look like, and, what the state is responsible for versus what the county and local agencies will be responsible for. And then we want to make sure that we provide that opportunity for input into that, so that even though you may not know what that completely looks like, although you've seen quite a bit of that here today, you have an idea of what you're signing up for. So it's really the assurance that's required for you to include in the CPP. And as long as you do that, then the rest of it is really once the full curriculum and training delivery approach is developed, it'll be later how you do that through implementation.
Yeah. Now, just because a training plan isn't required for the CPP, I don't recommend folks forego one completely, right? At some, there's got to be something local that your governance group can point to. Here's what we're doing. You may deviate from it, you may amend it, right? But there's got to be something documented in order for implementation to go well, regardless of whether you're submitting it with your CPP or not. And just another plug about this, you don't need to wait for the CPP template to start writing some of your decisions down in terms of who you're serving, what services you're bringing to bear. if you answer the questions that are implied in the implementation guide, you'll have a lot to cut and paste into that template should you choose to use it. Or if you just actually went through and answered the questions in the order the guide puts them in, that would work too, right? So there's all sorts of ways in which you can go about meeting the elemental requirements in ACL 2223. You don't have to wait for the template. You can start now. The holidays are coming. All right, next question. So Jennifer, I'm gonna throw this one at you. Can an organization function at all or have services at all 3 prevention levels? Right. Some efforts being more universal for families that haven't moved up to needing tier 2 or tier 3.
Yeah, I mean, I think we saw that earlier. We have agencies that were working at all 3 different levels. I think clearly, you may have universal programs that are available for everyone in the community, and then you have, targeted programs. Child welfare, you can certainly see that there are activities that the child welfare system is doing that are universal, public education campaigns about child abuse, things like that, but that they're also doing tertiary services. So yes, you can do all 3. And in some cases, it's really what you need to be doing so that you can reduce those tertiary services by building the primary prevention services up over time.
And just to I couldn't agree more with the having all 3 in place for your target population, right? Because essentially, right, it's when you miss them at the primary level, like 2 years later, it's the it's the neighbor of the family you did catch, but the neighbor you didn't catch is now needing targeted services.
Yeah,
and down the
even
road, 5 years more,
Yeah.
now they're at the brink of the child welfare system.
Yep.
So-
And even families that are getting tertiary services, already in child welfare, already in probation, could still benefit from learning about what are those community-based services that are out there. What are the natural
when you
supports?
get when you're
Yes.
unified.
Yes. So what are these things that are there that can help support them when they do move out of that tertiary level, or even while they're in the tertiary level, to help them prepare to reunify?
That's great. Thank you. All right, let's see. One that comes up often, Kelly. What is the projected timeline for the rollout of CWS Cares?
Well, isn't that the $1 million question?
Yes,
We know it's going to be a couple of years before the first version of CARES is able to be rolled out. I wish I could give you a specific time frame, but unfortunately, the board that is responsible for planning the development and rollout of that system has not yet released a time frame that we're able to share. So we're anxiously awaiting it along with everybody else. And I will say that, activities around the prevention program are already in development. I mean, having lots of conversations at the state and county level about what that will look like. So the work is underway. It's just the final goal is not quite yet clear.
Yeah, I think the couple probably can't get any more specific than a couple of years, give or take. Thanks, Kelly. And while I have you, will there be a format for claiming Title IV funds for training?
Well, and I'm not sure the perspective from which that question was asked. I think if you're a county and you have you already know how to claim Title IV-E, it'll work very similarly to the way that you already do that work. With new claiming codes specifically set. And I think, we have CFLs already out and available that explain that. If you're a contracted based organization, then you'll work with your local Title IV-E agency to get those funds passed through to you. And I think it'll have to depend upon the local contracting process for that.
Next question. Dan, I'd like you to answer this one. We use MI and have been for many years. We're at the point where we have trainers in our office and they do the monitoring for fidelity. Are we going to be required to show that the original trainer was Mint certified?
This is great. Stump the panel. So I don't know. You stumped me. Thinking off the cuff here, I don't think so. I think what would be required would be the fidelity measures. And so if that's a whole other discussion. If you know MI, you know there are multiple ways of assessing fidelity, some that involve audio tape recordings or coded interactions or rating scales. So that's why I'm kind of hesitating. I think we need to have that conversation first. And then if you're the folks that are delivering MI in your program participate in that fidelity monitoring and it looks good, I don't know why we would have to go back to the original, but TBD.
Yeah, but I think in terms of a frame to think about, the answer to that question, right? What is it we're trying to prove? Well, we're trying to prove that we're doing it right. And if we can prove we're doing it right, then
Exactly.
Who cares who trained us?
Right. Less about the credential. Well, in this case, less about the credentials of the trainer, since it's behind us now, more about fidelity of implementation.
Yeah, great. Thanks. All right. Let me see if I have any more questions. Will CBOs be trained to conduct formal safety and risk assessments like SDM? Kelly, what say you?
That's a very good question. So right now we're not planning to use SDM in the community-based pathway. It is something that we've identified for use in the Title IV-E pathway for child welfare services agencies. Probation agencies have their own set of safety and risk assessment tools that they'll be using. But when it comes to the community pathway, I think it's more complicated than just rolling out SDM. For the same reasons that we just recently talked about making sure that we don't unintentionally bring families into the system that we're really trying to keep out. So we're really trying to leverage the services that are going to be delivered to the family and really the relationship between the provider and the family to be doing that ongoing monitoring in the day-to-day work that they do with families. The curriculum that we develop will address that specifically and really identify, and it's going to have to be based on the services provided in the local prevention plan and how those intertwine. So a little bit more complicated than just putting in place a set of tools, but really that interaction with the family and how we monitor that on a regular basis. So more to come on that. I think, the way that we wrote it in the prevention plan also describes a little bit more. So if you want to take a look there, but recognizing that there's still more detail that has to be worked out.
All right, team, unless I'm missing something, I'm not seeing any more questions. Oh, wait. Hold on, there's one. Okay, I'm gonna read the question out, and then we can decide who answers it. So here's the question that the CFL, the 2122 states, quote, until the implementation of CWS Cares as the automated statewide system to collect and track child-specific 4E prevention case information and services. Wait, until the implementation of CWS Cares as the automated statewide system to collect and track child-specific Title IV prevention case information and services costs necessary to meet federal requirements is available, county shall not draw down Title IV federal financial participation, FFP, for child-specific prevention services. That means we will not actually be able to claim child-specific direct and administrative costs for another 2 years. We'll only be able to claim the administrative and training costs for the next 2 years until CARES is up and running.
That's correct. I mean, it's the reality of the situation we have to deal with. The way that the federal government requires reporting means that we have to have a system to be able to collect that. If you're familiar with CWS CMS, you know that that system is not capable of even being changed to collect the information required for federal reporting. And the CWS regulations, the federal regulations for our automation in California, require that we have one system in place to be able to collect that information. So the first system can't do it. We can't put something interim in place, and we have to wait for the third system, which is CWS Cares, to be able to do it.
Yeah. But Kelly, but this is to be able to claim 4E. Right.
Correct. Yes. And that's a very important nuance, right? So, and while this question looks to me to be worded correctly, you'll still be able to collect admin and training funding once the prevention plan is approved back to October of 2021. It's really those child-specific service costs and the case management activities associated with that cannot happen until we have automation in place.
Could they use the state block grant?
They can, yes. So for things that you can't claim yet, you can actually get started using your block grant funds.
And you know, in that way, being able to draw down 4E is a great sustainability plan for those services that you started up using the block grant.
Yeah,
right.
Exactly.
And here's a question, another question for CDSS actually. Am I understanding correctly that CDSS intends to develop statewide training programs that would address many of the workforce development requirements for the CPPs? What are the specific requirements that will only be met at the county level, and how does that impact the CPP?
So that's a good question. And I think that there is still more conversation that needs to happen before we can get to those specific requirements. But I think what we have is what we've shared today. The state plans to fund curriculum development and a T for T model. So we will pay for that T for T model to be available. And then after that, we'll have to see counties and local agencies kick in additional funding to make sure that they have trainers available. That may look different across the state. That is more feasible in some counties where it's not in others. And so we're trying to leverage our training partners. They have expertise in what particular regions need, and we'll be able to work through some of those details. And you know, our goal is to make sure it happens. And you know, if we have funding available to support where a county or a tribe is not able to do that, we just need to talk that through.
Okay. I think we are going to leave it there for today. If there are questions that we were not able to get to, or that sort of came in at the last minute as I was closing, we will make sure that we get those documented and answered as we've been doing in a Q&A document. So with that, I'd like to turn it over to Jessica at Caltrin to bring us home.
Thank you so much. And thank you on behalf of the attendees, to the panelists, the presenters today. Thank you so much. It looks like on our next slide here, we want to talk.
Yeah, go ahead. Sorry.
That's fine. So just as a reminder, this is a series. So there are additional series topics coming up, and we have a Q&A for this specific session coming up on November 2nd. You can find the link to register for that Q&A session in your chat now, so you can click that. That website also holds all of the previous and future trainings and identifying what to happen, you know, what's going to happen and when it's going to happen as well. On the next slide, what you should see, I know we talked a little bit about Caltrin today, providing free training in areas of development for helping professionals like you across the state. So what you're seeing on your screen are some of those upcoming training topics, such as utilizing logic models to demonstrate outcome accountability, which happens tomorrow. You can see all of the training topics and sign up for them on our website, which is caltrin.org. And lastly, for those of you that attended, just a couple last steps for you on the next screen. You should see very shortly in the chat a link to a survey. That survey will give you an opportunity to discuss your experience in today's training. It is a great way to communicate back to the panelists and back to the series designers so that they know, we know what you are looking for in the future. It's also a perfect opportunity to ask any questions that did not get answered for you today. That will be used, of course, for the Q&A session coming up in November. Outside of that, you can expect a 2-day follow-up email. That 2-day follow-up will have a copy of today's recordings, resources, and tell you where to go and where to get those. Outside of that, we want to say thank you for being with us today, and we look forward to the next session.